So for the management of arterial ulcer, you still need to use the SchrDbb algorithm. That you are going to manage first the disease. The disease is actually the arterial ulcer. Then the etiology of the disease is the arterial obliteration. The arterial obliteration can come either centrally or peripherally. If it comes centrally from an atrial fibrillation, you need to manage the atrial fibrillation, you need to manage the heart failure and all that. Is it clear? But the mechanism of the central is coming from a thrombus that we are going to speak about its management here. Is it clear? And then the complication of the arterial ulcer is that it can become gangrenous. Is it clear? And also it can become super infected. Those are complications that you have. You have gangrenous, you have super infected, you have amputation. So that those are the complications of an arterial ulcer, and you have to prevent those complications. So when you are speaking about the management of arterial ulcer, you need to say that you are going to manage first the arterial ulcer, and there is in the principle of management of an ulcer. Is it clear? Now you have to manage for the cause. The cause is an arterial or obliteration. The arterial obliteration can come from either centrally or peripherally, and you are going to manage the arterial obliteration. The next thing is to manage to prevent the complication from occurring in a patient that has an arterial ulcer. And then the last thing is to evaluate for the background, and you manage. If the patient is hypertensive, you manage. You have to stop smoking, you have to manage the diabetes of the patient and all the any other thing that can be cardiovascular risk factor in a patient. If a patient, for the novel cardiovascular risk factor, if the patient has HIV, is MS, have HIV, you have to control the viral load and all the other elements. So those are the things that we are going to visualize here. Now let's start with the management of the arterial ulcer. Is it clear? Now you need to know that generally management of ulcers is the same. When you manage ulcers, managing ulcers is the same. Is it clear? And the principle of management of ulcer is, the first is debridement, and then the second is wound dressing. Is it clear? The first in the management of ulcers is debridement. The second is wound dressing. What do you debride? We have already spoken in a tutorial of debridement that you have to debride devitalized tissues. You have to cut off devitalized tissue, a surgical technique done by a surgeon in order to remove the devitalized tissue and reperfuse the devitalized tissues. Is it clear? So that is debridement. You need to remove the devitalized tissues. Now we need to continue now by wound dressing. Depending on the phase of the wound healing or the stage of the wound healing, there are different wound dressing techniques which are being done that we have already explained in the tutorial of the wound dressing. Is it clear? So you need to know that for every ulcer, that is the principle of management of ulcer. You receive a patient with an ulcer, you need to know that every time you have an ulcer, you need to do these two major elements, debridement and wound dressing. Now, after the management of the ulcer, the next thing that you have to manage is the cause, which is the arterial obliteration. Is it clear? Arterial obliteration. Now, the arterial obliteration, generally, you need to manage. The principle of management of arterial obliteration is reperfusion. Is it clear? The principle of management of arterial obliteration is reperfusion. Is it clear? And reperfusion is being done by antithrombotics. Is it clear? And there are classes of medication of antithrombotics. The first one that has to be used is going to be the case of fibrinolytics. Is it clear? Fibrinolytics can be done. Is it clear? For reperfusion, you can do fibrinolysis with tissue plasminogen activator. You can do fibrinolysis with streptokinase or alteplase. Is it clear? So those are the different techniques of fibrinolysis that you have to do. The second antithrombotic technique that you have to do, you can use anticoagulants. Is it clear? Anticoagulants can also be used for the first 6 hours. You can use fibrinolytics. The next duration, for the next 3 days, you can use anticoagulants. Example, heparins, you can have warfarins, and you have oral anticoagulants that you can use. And then the next one that you have to use now is antiplatelets. platelets, is it clear, aspirin and clopidogrel, is it clear. Those are all the antithrombotic that you have to use in order to reperfuse the tissue. The reperfusion can also be done this is a pharmacological reperfusion. It can also be interventional reperfusion by interventional radiography, by interventional radiologists, where the radiologists are going to send a catheter for a thrombectomy. So interventional radiology and thrombectomy. Or you can have a surgical, it can be interventional from surgery. You have a surgical thrombectomy so that you can have a reperfusion of the tissue. Is it clear? So the reperfusions of the tissue can be done. The principle of arterial obliteration is such that you should do a reperfusion of the tissue. And then later on, after you have done the reperfusion of the tissue, you have now the management now of the background. Is it clear? In the management of the background, we said that there is hypertension. So you need to manage the blood pressure of the patient by keeping the blood pressure at the level of less than or equals to 140/90 millimeters of mercury in the background. You have to use the patient, you have to give statins to the patient in order to make sure that the LDL's levels are less than or equals to 60 international units. Is it clear? You have to make sure that you reduce the LDL level by using statins like atorvastatins. So those are goals that you have to use. The next thing, if the patient is hyperglycemic, you have to make sure that you use hypoglycemic drugs like insulins and sulfonylureas or biguanides like metformin, such as to make sure that the fasting blood sugar level of the patient is, the random blood sugar of the patient is less than or equals to 140 milligram per deciliter at any point in time. Is it clear? So the random blood sugar of the patient should be less than or equals to 140 milligram per deciliter, and also the glycated hemoglobin of the patient should be less than 7%. So all those are the characteristics that you have to do in order to control the patient from having again another event of arterial for an arterial obliteration. Is it clear? Now the next thing again is that the complication that you may have superinfection. So in order to prevent superinfection of the wound, you may give prophylactic antibiotics, which is taken orally. And you need to know that generally on the skin of the wound you have staphylococcus also. You can give prophylactic cloxacillin. Is it clear? And you can give prophylactic antibiotic to prevent the wound. You can also do daily wound dressing. Is it clear? Daily wound dressing is going to also help to prevent the wound from being infected. Is it clear? I've also forgotten that we have another one in arterial obliteration. You can use vasodilators. Is it clear? Like nitroglycerin, just like you use vasodilators in the case of an ischemic heart disease. Is it clear? In ischemic heart disease, you use vasodilator like nitroglycerin. You can also use those vasodilators here in order to do vasodilation at the level of the blood vessels, and that vasodilation is going to reperfuse also the tissue. Is it clear? So all that is used in the management of an arterial obliteration and arterial ulcer. The next thing in this we are going to visualize now the follow-up of a patient that has arterial obliteration and arterial ulcer.